This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I am excited to bring you my conversation with Dr. Rodrigo Vasconcelos about transforming physical therapy with value-based healthcare. In our discussion, Dr. Vasconcelos will explore the definition of value-based healthcare in the context of physical therapy, challenges in implementing value-based healthcare, specific outcomes and metrics used to measure value in physical therapy, the role of technology in advancing value-based care, a real-world example of a successful value-based care model in practice. Dr. Rodrigo Vasconcelos is a board-certified sports physical therapist and a clinical leader who integrates a value-based healthcare approach to treating sports, orthopedic, and chronic pain patients. With a Ph.D. and postdoctoral degree in rehabilitation, he is a recognized expert and lecturer, having delivered over 250 presentations on rehabilitation and value-based healthcare. If you find this conversation valuable, please subscribe to our channel, hit the notification bell to stay updated, give this episode a thumbs up, and share with your colleagues who could benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi, Rodrigo. Welcome to PT Pro Talk. How are you today?
Hi, Mariana. For me, it's a pleasure to be here with you. Thanks for the invitation.
Awesome. I'm super excited for our conversation. So let's just get started talking a little bit about yourself and your background for the ones that don't know you.
I'm starting the journey in physiotherapy in 1995. And next year will be 30 years of clinical practice. I'm a Brazilian physiotherapist. I'm living in Campinas, São Paulo. It's a city like 1 hour far from São Paulo, driving. It's a 1 million population. And I started doing physiotherapy because I was an athlete practicing judo. Judo is Olympic sports, very popular here in Brazil. And then because of the injuries, I have knee ACL reconstruction in both knees. Then I was interested because a lot of physiotherapists treating my knees, and also my family. We have 5 physiotherapists in my family.
Oh,
so
wow.
I have an influence of my uncle that was a sports PT before me. And so I have influence because of my sports, because of the injuries that I connect me with the profession, and also members of my family, also as a PT. And then I try to follow the profession, and then I go to specialization in sports physiotherapy in Brazil. The bachelor's degree here after the high school is 5 years, and then we seek specializations programs that is average 1 year in duration. Actually, in Brazil today we have a lot of residence programs like US. It's 2 years in different specialties, but in my time it was a specialization programs. They take 1 year, and then I went to Pittsburgh, Pennsylvania, in 2002, and then when I was there in 2002, I was mentoring by Dr. James Harrigan and Dr. Kelly Fitzgerald, was leader researchers in sports medicine and knee and shoulder rehab. And at that time, 2002, I was fortunate to know a lot of outstanding physiotherapy that was giving classes or finishing his PhDs, like John Childs, like Julie Fritz, like Dr. Richard Enhard, that passed away in 2008. He was the first president of IFONT, that is an International Federation of Orthopedic Manual Therapy. He was a chiropractor and also a physiotherapist. And Keelan Ensack, that today is the director of University of Pittsburgh Clinical Settings. So was a brilliant people that inspiring me to know that we need to get together science and clinical practice. And then I realized that a physiotherapist needs to be half scientist and half treating patients every day. And then I went back to Brazil. I started pursuing both things. So I was practicing in sports medicine and orthopedics. And then I pursued my master's, my Ph.D. in medical science at the University of São Paulo. University of São Paulo is the first one, top one university in Latin America. And then I did my postdoc in rehabilitation and in functional performance about spine rehab. And my master's and my PhD was about ACL injuries. And then today I work in the Instituto Mello. I'm a co-owner. It's a very reference clinic here that is orthopedics, sports medicine, and pain clinic. They have more than 60 professionals working together as surgeons, more than 20 PTs, and personal trainers, coachings that we work together, and as psychologists treating patients and managing complex cases. We work in 3 different clinics in 2 different cities, and also managing more than 30 different cities that patients look for us trying to resolve problems. So it's a full day treating patients and doing research and publishing papers, and half scientist and half clinician. So that's my daily basis today.
I think that's so cool that you are able to do both, like mix science and clinical practice and still like research and publish papers. I think that's awesome that you're able to combine both.
Yeah, actually we have a education branch. We had provided more than 30 international courses here. More than 18 PhDs from all over the world came here to Campinas and teach Brazilian physiotherapists. We are a very big nation of physiotherapists. We are 400,000 physiotherapists divided in 27 states. Only in my city, Campinas, we are 13,000 physiotherapists. So Brazil, it's a whole lot. It's a crowd of physiotherapists. Yeah.
Yeah.
We need a lot of education here.
Yes. And now jumping to our topic today, value-based healthcare. So how would you define it in the context of physical therapy?
Yeah, the concept of value-based healthcare, I started to get interested in my postdoc that was in spine rehab. We have at that time the chance to have a partnership with the top 1 hospital in Brazil, what they call Albert Einstein Hospital. And I wrote a project because they have the first rounds of a second opinion in spine surgery. So when a doctor demanded surgery for a patient, then the patient go to this hospital and he passed to a group of clinicians, doctors, to see if the prescription of surgery was okay or was reliable for that patient. And then if it was reliable, the patients go to surgery. And if it's not reliable, they go to a physiotherapy program. And they publish the first outcomes and show that more than 65% of the patients didn't go to surgery. Surgery was not necessary. So there was an over-indication of surgeries in Brazil. And the first paper was having a lot of issues here between doctors, and also the media covered a little bit the over indication of surgery in Brazil. So the second generation of this study, we entered using our physiotherapy program protocol that we call subgroups, treatment-based classification, actually a little bit modified because I also am a certified MDT training physiotherapist. And then we put together also pain education, neuroscience education. And for chronic patients, also we use a little bit of CFT, cognitive functional therapy. So if the patient is acute patients, or if the patient is chronic, nociplastic, we use tailored treatments and a very good screening to use in this patient. So this program, they become Ph.D. thesis of today my partner, Isadora Oliveira, and actually was a 200 patients that was indicated surgery. And then by the screening, 100 patients go to surgery, and another 100 went to this PT program during 1 year. Actually, it was 20 PT visits during 10 weeks. And then we follow up these patients during 1 year. And at the end of the 1 year follow-up, only 6% of the patients in our group, PT group, actually need to go to surgery. And one PT treating these 100 patients, they save more $500,000. Just one PT doing that. So we send this data for some congresses, and then we are working the first publication. That was the PhD thesis that Isadora defended. And so the value-based healthcare, actually, they have three main purposes. The first one is the patient experience. So all the treatments is focused on the patient. The other one is need to save money. You need to be cost effectiveness because we know that the health system in the future have a lot of challenges, mainly on sustainability. We know there is a lot of problem with that. And the third one was we need to collect data. We need to collect outcome. And these three main purposes focus on the patients and focus on collecting data and also saving costs is the future of healthcare. So we know that is a game changer in my opinion, but we know that we are only in the beginning, and we only in the beginning because we have a lot of resistance from the system to use 100% of value-based healthcare.
Okay, you just said so much. I'm gonna go back and start with my questions. So the first, you said that when you partner with the hospital, 65% of the surgeries were not needed, right?
Yeah. Or because the diagnosis was wrong. I mean, there's no sensibility or specificity. Like there are some patients that have just a calf muscle injury, and they think there was a sciatica, and then they were sending these patients to surgery. Other patients was a fibromyalgic patients, and actually there is no need of surgery just because there is showing a disc protrusion, and so on. So a lot of mistakes on diagnosis or over indications because financial purposes.
And who are screening those patients?
In Brazil, the system was the second screening was a physiatrist, orthopedic surgeon, and not focused on spine. And there is a third one. There was a spine surgeon. So the PT was not member from the group that was doing the second opinion. After the group that decided that the patient is not needed surgery, then they send the PT to the PT for the physiotherapy on the program, and then the PT would do the first evaluation, and then the PT have like free will to prescribe whatever they want. So in this study, we use mainly a modified treatment-based classification using more intensive MDT screening, and also pain neuroscience education, and also a lot of prescribing exercises to these patients.
And so at first were doctors that were screening, and then after the PTs? Is that right? No?
Like the program was a partnership with a health insurance company. And this health insurance company, after a doctor, a physician, a surgeon inside this company defining that the patient is going to surgery, then the health insurance company sends these patients to the doctors to the second opinion.
Okay.
And then this group of second opinion will decide if the patients definitely we need surgery, and then they go back to the surgeon that prescribed the surgery, or if it's no surgery needed, then they go to the PT program, and then a physiotherapist will evaluate these patients to start the program. So if the patient fits to manipulation or manual therapy, or if the patient fits to centralization, or if this patient is a chronic pain osteoplastic, need neuroscience education, psychologists, or these patients need exercises, and so on.
Okay. And on that group that you said that only 6% end up needing physical therapy, it's the same group that was recommended that surgery?
Yeah, in the beginning, all 100 patients, if it was only depending on the first spine surgeon decision, all them need to go to surgery. But after he passed to the second opinion and also to the 10 weeks of PT program, only 6% of these patients, or 6 patients, actually need surgery.
Yeah, that's crazy. And so you said that that's the future, but you're still like, the system has a lot of resistance, right? So what are the main challenges in implementing the value-based healthcare, in your opinion?
Oh, it's so many challenges, because today we are priests preaching in the desert without nobody want to listen. And when you talk about physiotherapy, we have, for example, we can save money for the system in spine conditions. We can save the money in knee OA, in hip OA, and also in rotator cuff surgeries. So these 4 mainly conditions: the patients that go to total knee replacement, total hip replacement, surgery for a rotator cuff, and surgery for spine, is 80% of the costs in musculoskeletal conditions. And we have a lot of evidence-based that conservative treatment can give quite a lot of life of the patients, and also you can save money for the system. So the problem is, in Brazil, particularly talking about my region here, for example, we have a second program here in Campinas, a second hospital look for us and make partnership with us during 3 years. But this program was treating patients, not only patients that was sent to surgery, was any patient with back pain, So we have 500 patients during 3 years. And we show the results. Now we send it to the World Congress of Pain. This project, they became a master's dissertation of Ana Emilia, one of physiotherapists that we work together, also in the team. And we save money. We save 40% of emergency departments. During the 3 years of the program, treating 500 patients, we have only 2 surgeries. And only 2% of the patients need to go back to treatment again during the 1-year program. I mean, the patients are, they receive liberation after PT, and then only 2 patients need to go back during 12 months to start again the program because they starting to feel the pain again. So we show so many savings, but even that, the program was ended because the number of surgeries drop. So when the numbers of surgery drop, the hospital decided to finish the system because we have some conflicts with doctors inside the program. So there is just, when the PT is starting to work, then we save money, but then we reduce the number of surgery in the hospital, and this is not good for the business. Because the only thing in Brazil they want to promote the values-based healthcare, because if a hospital show that he's using the program for a health insurance system, then a lot of companies of health insurance system is starting to send patients to the hospital. So if I have in 100 patients, I have only 7 surgeries, and then I show to the other companies, then if they send to me 1,000 patients, then I will have 60 surgeries. So I will increase the amount of surgeries that my hospital is going to do it. So if I show that I have a very good PT program, everybody going to send spinal patients. And if I send more spinal patients, is there more probability that surgery going to happen? Because at least 6 and 8% of these patients will need surgery. So actually, it's not because they like PTs. It's because you can increase the amount of patients that the system is going to send to your program. And then you can do more surgeries because actually it's a statistics, right?
That's crazy, Rodrigo. I'm so shocked what you said about like the results. Like you had this great PT program, you had amazing results, you saved a lot of money, reduced the number of surgeries, and still the program was ended. So that's crazy, and it's sad that that's how the system works. So
actually, thanks God, we have 3 years of data, so we can run a Masters of Science program. A student, Ana Maria, we were able to finish the data, and we are sending to publication the results. And the people here that are watching us and hearing us, it needs to know how the Brazilian health system works. Because the Brazilian health system, PT is working 3 different ways. We have the national public federal health system that we call SUS, S-U-S. So any Brazilian here that have any problems, any injury, can be treated for free in any hospital. Only you need to show your ID. And the PT program of this system is, we have some locations that have excellence care for neurologic patients, but just a few ones. The major programs of PT is just one PT treating a lot of patients at the same time, like 6, 7, or 8 patients at a time. And the reimbursement is so few bucks that I'm ashamed to tell here.
mm-hmm.
So a physio can receive money from the government. And there is a second system. So our national health system, the federal one, 150 million population in Brazil depends 100% of the care of the federal system that is free for everybody. And then we have 50 million people that have private health insurance. We have a lot of companies here. And these companies also pay so little for the Brazilian PTs. There is no difference to the public system. And is one PT working at the same time with 5, 6, 7 patients. There is no evaluation process. And all patients do the same. There's many sections, and how the health insurance companies pay so less money comparing to the other systems, then the PT works with the same time with many PTs, and there is a lot of sections. So one patient with a back pain patient, normally they're gonna do 60, 70, 80 visits in 3 or 4 months. They go every day, and they do only 20, 25 minutes of PT section. And there is
That's
a whole
crazy.
sector the sector that I work, that a very good PTs can make a very good money and honest money in Brazil. There is a totally, we call pay for their own pocket, or the patients pay. The patients is a source of payment. It's a 100% private. The patients pay for their own pocket. And this is our system that we work today. And the best physios in Brazil only work with this system. They don't depend on any health insurance company. They don't depend on any federal global health system in Brazil. And then you can have your clinic, your private clinic, with good equipments and with PT visits, 1 hour with a consultation, first consultation, and just a few sections. Our team that is formed by 24 physiotherapists, our average number of sections, PT visits, is 6.6. We have an NPS, that is patient satisfaction, of 97%. And we treat more than 30 different locations or cities that come for us because we are references. So more than half of our patients is patients that already did 30, 40, 50 PT visits with a private system and doesn't work. And then they try, then they understand that they need to go to the private system and look for a very good PT and pay for their own pocket to have a quality of care that deserves, and the patient will get some outcomes that he deserves. So that is the system in Brazil. So the second project that we have, we do some new thing in Brazil, that if the PT will have 1 hour of consultation before starting treatment, and every patient have just one PT, we treat one patient every 30 minutes. So this is unthinkable in Brazil in the health insurance system before. And we work like this during 3 years, then we collect data, and we have a very good results to save money, to save number of surgeries. But still then, after 3 years, the program was ended, because then the hospital that was actually starting this program, he was expecting a lot of companies, health insurance, that we will provide patients, and then the number of surgery will increase. And this has not happened, unfortunately. And then they ended the program, even with extremely good and excellent results. So this is one of the things that the value-based care healthcare in Brazil is still a dream, because there is a culture that is made for the fee-for-service. So fee-for-service, like many sections, if you do a lot of package of sections, then we will receive more money. And we know that this is not going to work in the future. Another thing is the private physiotherapists, they think that when you collect the data, you are doing research to do a Ph.D. or to write an article. And there is nothing we do with that. You collect data to show how good you are and to measure your outcomes, to measure your results, to measure if your clinic have a lot of success, clinical success with your patients. And then you can measure if your team needs to improve or not. And then you need to compare with a benchmark, with the other clinics, with the same specialty. And then we can grow together as a profession. Because in Brazil, we are a slave of a philosophical debates about different kind of systems of physiotherapy. So just philosophical debates that one system is better than the other systems. Oh, the guy that do osteopath is better than the guy that do chiropractor, is better than the guy who do fascial manipulation, that is better the guy who do Pilates, and then the guy that do core stabilization training, and the guy that we're gonna work with acupuncture. And then this kind of debate is only philosophical. Nobody's collecting your data, showing how your clinic is going. And then we can compare, and then we can learn with each other. So we get the same patients, chronic ones, below 60 years old, with radiculopathy, and then we can follow up these patients. And you can do whatever you want, but let's collect the same standardized outcomes, and then we can learn with each other. So there's like a afraid or a fear of everybody to show your results that in sports we see every day. A very good athlete, you can see all his performance during the year. You can see how this athlete is good in any kind of sports field. But a surgeon and a physiotherapist, they have afraid to show their results. Even an Uber driver, they have their outcomes, the number of stars they receive of the clients. We in Brazil are afraid to collect data and show how good you are, or how you can also learn a lot because your clinic is not having good outcomes. And then because the value-based healthcare is about that, it's meritocracy, that the people that is performing more, delivering more value to the patients, they need to receive more money. And they need to be paid for the source of the payment. And we have a lot of resistance about that, even with doctors and also with physiotherapists. And the other problem is also the structure for us to collect data. We miss a lot of data because even the patients, we have problem with the patients to respond the outcomes, to respond the questionnaires. So we have experience here is more than 50% missing data, because we're solving this because we send the questionnaire by email, and now you're changing to send to the message or for WhatsApp message. And also we have a PT only calling patients in the follow-up day. And then we started to grow the answers. But in any kind of program, United States, Europe, or Brazil, even with hospitals, they're trying to implement value-based healthcare. The greatest challenge is culture, is collecting data, and try to make the patients to answer the questionnaires for us to collect this data science and do data analytics. That is the main challenge that we have today with value-based healthcare.
So like it doesn't seem like the hospital is gonna work like right with your experience and everything that you've done, and it doesn't seem that it was valued as it should. So like in your opinion, how can PTs be rewarded by their services? Do you feel like it's just the patients paying out of pocket in Brazil, for example? So how do you see that? How can you be rewarded for your great service?
In Brazil, I don't believe that a health insurance company will look at, or we try to find me, even if I already did many dozens of conferences, only medical doctors with medical executives showing data. I mean, we always feel like we are showing some challenging for them, because I am a PT. Even if I am having a Ph.D. and a very good reputation in Brazil, they listen everything. But when we starting to try to implement something, there is a mini conflict of interests. And this conflict of interest also have a lot of crisis in health insurance company in Brazil. A lot of health insurance company in Brazil is bankruptcy, because it's a challenge between health professionals, executives, the government, and it's a very delicate issue if we discuss. But I think that in Brazil, specifically in Brazil, the work that needs to be done, and we are realizing that, is the patient. The patient is realizing that he's asking and showing and trying to find who is the best doctor or physiotherapist, who is showing outcomes, who is providing outcomes. And then this third system, that is the paying for the own pocket or co-pay, then this patient is looking after these clinics that is demonstrating outcomes, that is demonstrating ethics and evidence-based in doing work in social media or marketing, showing NPS, showing Oswestry score, showing number of patients that doesn't need surgery, and collect data. But honestly, in Brazil, to see like health insurance company that are going to work together as a physios to do like first contact, because in Brazil we can be a first contact, I can prescribe exams, I can order exams, and I don't need doctors to send patients to me, only in the private system. If the patients pay for their own pocket, I am first contact. And in our clinic, we are 51% first contact, and 49% we receive patients from many different doctors, from orthopedic surgeons, neurosurgeons, in different kind of fields, and hematologists. But in 51%, the patients look first for us as diagnostic and referral, or if the patients can also do PT, because there is no red flags, and the screening shows that the patients can start physiotherapy.
Yeah.
So it's a challenge. I mean, we are organized in Brazil. They have they have, for example, awards. The Brazilian awards in ValueBased healthcare. A hospital, a system, a group of neurologists in Joinville. It's a city located in the south of Brazil. They won 2 international awards, and one was the Oscar of ValueBased healthcare. That was in Switzerland, in Europe. That is international ValueBased healthcare. That the entire awards and projects, and they're elected the first one, and they started in 1995, and they received the award last year in 2023, and it was a program about stroke, and they could control the whole chain, prevention of strokes in the population of Joinville, a fast diagnostic and triage to the patients receive the best treatment in the few hours after stroke, and a multidisciplinary team to treat these patients, to do the rehabilitation of these patients, like physical therapists, occupational therapists, nutritionists, phonoaudiologists. And the result was amazing. They decreased 37% the incidence of stroke in the population. They decreased in 58% the lethality of stroke in the population. And then they increased 78% the functional recovery after a stroke. They changed the entire system of the city, and the partnership was with the public hospital. So it was an amazing program. And then they are teaching more than 20 countries in Latin America, because then they need to be scalable. When you have an example of this kind of success, that you use a multidisciplinary team, you have the government, you have hospitals, you have a multidisciplinary team, and you change the culture of the population. That is a value-based healthcare. And we can do that with the spinal pain, for example. But the problem is every discipline, physiatrists, hematologists, neurosurgeons, orthopedics, physiotherapists, chiropractors, everybody's talking different language. We are not working together. We are competing against each other. And this is not going to work.
Rodrigo, guess what? I'm proud of my city. That's where I was born, in Joinville.
Yeah, it's a joint VASC called the program. Joint VASC, joint of joint, and
Uh-huh.
VASC, VASCO.
Uh-huh.
It's an amazing program, and we are proud because a Brazilian program won the Oscar of value-based healthcare.
What a coincidence. That's funny. And so could you just share with us some specific outcomes or metrics that you use to measure?
Yeah, I'm very excited about that because we made a software. In my postdoc, we starting to develop a software that we call the company called Future Joint Data. Is made by PhDs and surgeons. We are 6 owners, and I developed all the all algorithm in all softwares, and they're made by joints and pathologists. We have the spine data, we have knee data, hip data, we have shoulder data, and ankle data. So we use we just finished the spine data that is more than 204 papers, scientific papers, only randomized control trials, systematic reviews, or a meta-analysis that we made for physical examination, collecting data analytic of every patient, seven dimensions in psychosocial like self-efficacy, kinesiophobia, depression, stress, anxiety, and work and quality of life like obesity, like sleep problems, sedentary life. Then we apply questionnaires, and then we do physical exam based only in sensitivity and specificity of any physical exam. And then it's like a Waze or Google Maps that follow if the patients need surgery or epidural blocks or is 100% conservative treatment, or if the patients need psychologists because they have depression, stress, or anxiety. And then the program of rehabilitation, if the patient needs centralization, or if the patient is nociplastic, or if the patient is neuropathic pain, or if the patients need immobilization, or if the patients need motor control, or if the patients need functional optimization. And then we collect data from evaluation, 6 weeks, 3 months, 6 months, and 1 year. So it's sent it automatically by email or WhatsApp for the patients. And then we can make decisions. When you collect data, then we make decisions and the patients show. And we perceived that actually we have 7 billion of subgroups because the amount of data of that patients at that time frame in their lives, only that patients can collect that amount of patients that we use also history, visual analytic scale. We use global perceived effect. We have start back. So we have a lot of things for the patients that is acute. We have like percentage if the patients can become chronic. If the patient is chronic, we need to see the 7 dimensions if the patients need psychologists or not, or the patients actually have a peripheric nociception that is going on, and we need to solve it. SI joint or is a spinal stenosis. So it's all like a map that we go in and try to help physios that are gonna input data of that kind of patients. So we already collected 4,000 patients, and we did a lot of we call MVP and minimal valued product, a lot of meetings, and we're gonna use this using technology. And we know today the performance of each physiotherapist inside the team. So we know the physiotherapists that need more training to work with spinal patients, or if we know that kind of PT they don't want to work with spinal pain patients, and then they are reflecting about this, and then this patient say, I don't want to work with spinal patients because I know that my outcomes is not going good, so I prefer to work with the sports patients. I work with sports physiotherapy or with shoulder patients that I have more skills to work with, or the PT that wants to work sincerely with a chronic spinal pain patients. Then we're gonna put more training in this kind of PTs.
Yeah.
So we know what PTs is in the first top 5 and the PTs that need more training. And then we can able to see the outcomes of the entire team, and also you can see the outcomes of each one of the PTs in our clinic. And it's interesting because our measuring of success, we did you need to be a Oswestry score below 20%. We need the visual analytic scale in the last 7 days. The worst moment of the day needs to be paying less than 3, between 0 and 3. The global perceived effect, we use -5 and +5, and +5 will be total recovery, and +3 will be much better. So the patients need to combine 5 outcomes. Needs to be less than 20% of Oswestry for low back, for example. Needs to be with pain less than 3, between 0 and 10. Needs to be with global perceived effect at least with +3. And they need to achieve the MCID of pain that at least decrease of 2 points in visual analytic scale. And also they need to decrease 10 points in Oswestry score. So if they have 4 category of these 5, the patients will receive discharge. And we need to see then in how many PT visits the physiotherapist could achieve this outcome. And how many was the costs, how much costs to the patient. And when you have a lot of clinics using the software, then we can do and perform congresses, international symposiums, or forums that we're going to invite people that show the best results, and not going to invite people that is my friend, or the people have a Ph.D, or because they published some papers. Then we're going to discuss the real life or real world data. And then we can learn with each other what kind of treatment these people did.
That's awesome. Is this software available just for your team, or is open to?
We're gonna in 2025 we're gonna open to signatures by month, and it will be a very cheap value because we want everybody can use it. Like would be like the price of a 1 PT visit a month, and because we have a lot of also. We need to everybody's using it because we want to see and compare data from different locations, different kind of clinics, different kind of office. And also is a good thing is when you use the software, if a chiropractor or an osteopath or a fascial manipulation or an acupuncture, they want to use the software and they not is tended to use evidence-based guidelines treatment that the software is indicating. They can use whatever they want, but they need to collect data because the software will fire the questionnaires automatically for all patients in the follow-up data points. And if any patients we starting to respond, they're going to receive the graphics and to see what is the outcome.
That's awesome. That would be so cool that then you can compare everybody. So you have to translate it to English now.
Yeah, it's because Paulo Teixeira is one of the co-owners. He's have a PhD from Harvard. He's my associate here. He moved out to the United States, and he finished his postdoc in Harvard actually. And
That's
he's a
awesome.
brilliant guy. And he will be our United States branch because also we need a lot of license to open the United States. But first we need to test the software in Brazil to see what gonna happen with the culture to collect data, the culture to have time enough to look at the patients, to talk to the patient, to take in the history, to do examination. And because in Brazil, we have a lot of PTs that have only 10, 15 minutes with each patient.
Yeah.
And
Yeah.
this is a problem.
Yeah, that's very exciting. That's very exciting. So, and that's how you see the technology playing a role in that? When you mean the technology, you mean that software that you are developing?
For me, the technology is facilitating the way that a physiotherapist will collect data, because you have the history, you have important questionnaires like the red flags, yellow flags, then you have the physical exam, and then you're gonna see the MRI or the X-ray. Then all this data, you need to find a path to show to the patients what is the path that the patients, for example, have 10 years of back pain. It's impossible for being 15 minutes of consultation to help this patient.
Yeah.
So the amazing thing is it could help a lot of patients that say, hey, your case is surgery. Your case, it's not surgery, it's physiotherapy. And what kind of physiotherapy is this one? You need to do this kind of protocol, and also you're going to need a psychologist, and also you're not going to need mindfulness, and also you're going to work with this kind of approach with a lot of education. And when he see the data and he see that we are collecting things, he perceived that the care it's focused on the patient and not in the professional, you know.
Mm-hmm. And I think one big challenge, as you mentioned before, is collecting data. So do you find that you're being more successful collecting data by like WhatsApp and like maybe messages?
We're running different tests.
Yeah.
Because you need to be the more cheap way for that physio that work alone in his office. So the software you're gonna fire in the specific follow-ups, like 6 weeks, 3 months, 6 months, they're gonna fire email. They're gonna send WhatsApp, and this is good because they work as a marketing, because the patient realize that the professionals is interesting in his case. The thing is, if I have 100 patients treated and only 35% responded, it's okay, because I will saving these patients. And when I have 100% responses, I have graphics and outcomes of 100 patients that responded my questions and collect data. And then I will have my benchmark to start and show it to everybody. Doesn't matter if I treated 200 patients, only 8 patients or 15 patients respond. I will give him time, and you're gonna accumulating with the time more patients that respond all outcomes, and then your story will be made, and then you're gonna realize actually, and that's my dream. For example, I receive a lot of PhDs from all over the world here to do lectures, and I only invite these people because of a paper that was published, a randomized control trial at all. But I never invited, for example, a professional that he showed his outcome, his performance in that thing that he's gonna teach. Because if I try to follow like a new guru that is trying to show how I'm gonna treat spinal pain, and they collect the data, and then I say, oh, I know that I have 61% of success in chronic pain patients, spinal pain patients in lower back. If this researcher or this clinicians from Europe is coming here and he's also have 61%, I'm not going there because our performance is pretty much the same. But if I saw a guy, or I see a guy or a physiotherapist that's showing that he has 74% of success in chronic spinal pain using the same outcomes, I'm going to New Zealand to work with him or to learn with him, or to do a workshop with him because I want to learn, and not just because I'm assuming that his theory is gonna help me with my patients. That until now we all do that, right?
Yeah. And you're not gonna follow what is trendy. You're gonna follow what works. So that would be like a dream to our profession as a whole.
Yeah, and remember today, what is a clinical clinical significance? It's 1 point in the visual knowledge scale between groups in chronic patients. 1 point only.
Mm-hmm.
It's clinical relevant.
Mm-hmm.
And for example, Westray score, it's 10 points, but they're not using cut-off values.
Mm-hmm.
That is important. But then we are using, and the literature is starting to change, for example, for hip, for knee, for shoulder. There is a new way for you to see that we call PASS, P-A-S-S score, that it's when the patient says, hey, this shoulder, after 6 months, I am okay with that. I can stay with this shoulder. I'm happy with this shoulder. The outcome for now, for me, I'm not going to complaining. I can stay with this shoulder. So the patient is happy, is satisfied with the functional outcome. So they're using the global perceived effect. For example, the patient say that is much better or extremely better. Then they do a correlation with the points in different questionnaires. And then you can use the points of that questionnaire. What is the percentage of your patients they achieve the PASS score? That is the truth, actually. So what is your score after hip arthroscopy for impingement, hip impingement, for example? What is the number of your patients they achieve the PASS score? What is the number of your patients achieve the PASS score after a rotator cuff repair? And then we can compare the truth about my performance comparing to your clinic, Mariana, or the clinic of everyone.
Mm-hmm.
For example, I was joking, like every Uber driver, you know how many stars they have. You're gonna find a hotel to stay in your vacations. You see the score of the hotel and the price, and then you're starting to look the ranking, and then we need to change our minds and trying to show scores, performance, and ranking of our clinics.
Yes. And like for the physical therapists that are listening to us and like don't have access to a software like that, or how would you advise them? What would you advise them to do to start like keeping track of their outcomes?
Today is very easy because all questionnaire is for free, and you can use questionnaires. There is very short, brief period of time that a patient can complete. Like if you want just a visual analysis scale in spine in those Westray and a global perceived effect, then you can have idea, and you can put in Excel program, and they are going doing alone, not with intention to publish anything,
Mm-hmm.
just to see your truth. You need to know how good you are, because in Brazil, in the private clinics, they even don't know when the patients come to the first visit, how many patients didn't go back to starting the treatment. So you need the data analytics. The future is data analytics. And for me, when you have that, so you need to use science. I use a lot of PubMed, and I'll use a lot of the Pedro scale. With the Pedro is for free to see how quality was that paper, because scientific papers is my tool to work with my patients, is to trying to find a way to treat my patients. But I'm obsessed to see my performance as a former athlete. You need to see your performance, and the patients deserve that. A physiotherapist that wants to be better every day, because we know that followers in Instagram don't tell how good you are. A full agenda a full agenda in your clinic doesn't they're not going to show if you're good or not, because you can do a very you can be a liar. You can use a very good marketing. You can use a lot of money to do like sales from internet for Google Ads, and then the patients are looking in your clinic waiting for a miracle, and you don't collect any data at all. So this kind of signs, like full agenda or specific a lot of followers in Instagram, don't tell if you're an expert or not.
Yeah. And for sure, for us to be better as a profession, like we need to be collecting and tracking outcomes so we can see how we are doing as a whole. Now, that's very exciting. I think it's the future. I don't know when it's going to happen, if it's going to happen.
Yeah, already started in the United States. In the United States, there was a lot of programs that are using ranking. A lot of, I think the only way in Brazil they implement was the health insurance company demanding and obligating all health insurance company professionals to fill out the electronic data of the patients, and all health insurance company here is worried about what is happening with the economy in Brazil. A lot of people here, in Brazil, the population is getting old, and a lot of doctors is demanding surgery a lot. So the system is going to break, a collapse in any time point. We know that. And in Brazil, it's more expensive for you to try to get a health insurance. And there's a lot of denying procedures. So the system is going to enter in collapse at one point. And we hope that the patients that pay for their own pocket and they see value about the work of physiotherapists. In Brazil, in my region, in my reality, is the only way that you can be happy to be physiotherapist, to be a physical therapist, that you're going to change lives and you're going to make a lot of money and you can be happy with your profession. In the federal health system or in the private health insurance system in Brazil today, it's a challenge for the 400,000 physiotherapists. It's a challenge.
Yeah, and it's just sad that that's how the system works. And if I wish they would see the value and reduce costs and would help the system as a whole. But we know that it's a lot harder than. There's a lot of resistance, as we talked before, because the way that the system works today benefits certain people, and it's just tough, unfortunately.
The problem is that people is dying because of this kind of care. And also, you see in the United States, the opioid crisis, and we see the global burden of disease. For example, in musculoskeletal disease, we know that 100 years ago, the people don't have so many disabilities comparing to today. But the patients 100 years ago with diabetes, today with the technology, with the advance of science, they are living better. But when you're talking about chronic pain or a musculoskeletal pain or a musculoskeletal system, the patient is getting worse. The functional disability is only increasing. Even with a robotic surgery, even with a new kind of medications, even with the new technologies of rehabilitation equipment, we're not changing the patients. We're not changing anything. We're getting the system more expensive and with more chronic pain. So one day we're going to get collapsed if you're not changing. And the only answer that I have today is to implement 100% of value-based healthcare. The culture of how we deliver outcomes to the patients.
Yeah. And in your view, how is that going to happen? Is it going to happen?
I don't know. I only can change my reality. And my reality in my team, I am as a leader, I have the dream that in 5 years we have all softwares that was already made, implemented, and I will know all data that enter my clinic in every patient, how our team is working, how my team is delivering performance, and how I can make progress after that.
Mm-hmm. Yes.
I only can change my reality.
Yeah. Start working with your patients, collecting your data and improving your outcomes, right? That's what we can do. Rodrigo, any other tip or advice to clinicians that are listening to us before we wrap up?
Oh, I think our profession is one of the best professions in the world. I know that it's very difficult, it's very demanding, demanding mental health, demanding in physical health. But I think we know that the population in the world will need physiotherapists every day, and I don't think that we can be replaced by AI. I think the connection with the patients, the empathy, the compassion, and the guide that we do for patients, this is not be replaced in the future.
Mm-hmm.
And for me, as we say in the beginning, for me, a clinician needs to be half clinician and half scientist. I mean, how to read a paper, how translate that data for your real world or for the patients that is in front of you. If you do the both things, you're gonna be the top 10 physios in your region, for sure. But you need to love people, you need to love treating patients. And you need to find a way to demonstrate value in your community. That is, for me, is the way that we need to treat patients and work as a physiotherapist.
Yeah. And just one final question before we wrap up. So when a PT is designing, what are the things they're going to measure and the outcomes they're going to track? So you mentioned something about psychosocial, you mentioned pain, like some questionnaire, right, specific to the body part. Like in general, do you have any suggestions for like what PT should be tracking?
The problem is because we don't have standardized questionnaires for every joint.
Mm-hmm.
For example, knee ligaments, we have 4 or 5 different types of questionnaire.
Mm-hmm.
So that's what we made, is not using all of them because it's time demanding.
Mm-hmm.
And you need to choose one that when you search in the literature,
Mm-hmm.
and you see that the majority of researchers around the world is using that questionnaire, because then you can compare
Mm-hmm.
the outcomes.
Yeah.
So be careful to not using questionnaires that is not using generally for everybody, because then you're not going to have benchmark to work with, because you need to compare. We need to show the results, the outcomes to our patients. At the same time, they're reading, like, for example, comparing like a bloody exam. Because when you see your bloody exam, you see the reference, if your exam is good or not. So when I show a also history, for example, for a patient, they know that the patients usually go to surgery with a 45% of disability. They know in the score that the normal population have a score between 0 and 12%. And they know that the discharge of physiotherapy is when they are below 20%. So after that, they know if they have 35% of score in Oswestry, they know that it's below to get surgery, but they are far away from the people that is normal population. Then you need to pursue that score when the patients need to do the physiotherapy to try to achieve that.
Mm-hmm.
So the patients understand the numbers when you explain to them.
Mm-hmm. Yeah. Very cool. Rodrigo, anything else before we wrap up?
I think it is the value-based healthcare. If you guys want to learn the there's a book, a classic book they call Redefining the Healthcare. The author is the Pope of the value-based healthcare. They call, I forgot his name. I have a blank here. Michael Porter. He's a professor of economy and administration at Harvard. And they initiate the movement of value-based healthcare after a member of his family was poorly treated by the U.S. health system. And then they realized that why the companies that is not in the health system demonstrate performance every time, and why hospitals and companies is not demonstrating outcomes. So then they start this movement to movement-based healthcare, value-based healthcare. So it's Michael Porter, Redefining the Healthcare. It's the book that you need to begin to understand. And also, looking the YouTube, you see a lot of lectures about Michael Porter, and he's speaking.
Okay.
That is
Very
truly
good.
inspiring.
And if people want to reach out to you, Rodrigo, is there a way that they can contact you?
Yeah, I am the Instagram. It's Rodrigo A. Vasconcelos. It's actually is a different one. I hope Mariana can put this below the video in the YouTube.
Yeah.
And also our clinic, Instituto Mello in Brazil. You just put in the Google, you're gonna find the first page. Then you can find our clinic. There is a virtual tour that you can walk inside the clinic, and then you can see one of the 3 clinics that we work every day.
Awesome. Rodrigo, thank you so much for your time and for sharing your passion. I can tell you're passionate about the topic, and I think what you are developing and creating it's an amazing tool, and I hope that we can get people using it and collecting more data so we can have a different conversation in a few months or years and come back and check how everything is progressing.
I hope so, Mariana. I'm so glad and I'm honored for you to invite me, because I watch a lot of your videos and podcasts with really a lot of important people for our profession. So for me, for you to call me, was very happy, and I hope to have some small contributions for your work, and keep doing an amazing job. That is this interview with a lot of people that inspire me.
Awesome. I appreciate it, and I'm happy to have a fellow Brazilian here coming to share all this knowledge with us. So I appreciate it.
Oh, thanks. Thank you very much.